everyone. Looks like we're live here. Welcome to our webinar with Excel Health Plans and Hint Connect. My name is Beth Holmes. I'm the head of Hint Connect, and I'm here with Dr. Dave Cameron and Mike Patton. So I'll let you guys introduce yourselves.
Go ahead, Mike.
Hey, thanks for having me on, Beth and Dave. I'm Mike Patton. I'm the president and co-founder of Excel Health Plans. Pleasure to come from you today. Actually, I'm in Las Vegas at the moment, and originally from Denver, Colorado. And we have a partially self-funded health plan, which really helps DPC providers as well as employers control and contain healthcare costs.
Yeah. And my name is David Cameron. I'm the Chief Medical Officer at Hint Connect, and I'm also a DPC doc. I've been doing direct primary care for the last 12 years, and my practice is here in Littleton, Colorado. It's called Pure Family Medicine.
Awesome. Thanks, Dave. Thanks, Mike. So today we're going to talk a little bit about how DPC can pair with larger health benefits. This, we've heard, is a challenge for many direct primary care practices who are trying to work with employers, and they get employers excited about the direct primary care offering. And then when it comes to pairing the direct primary care offering with the larger benefits package, the relationship and the deal kind of falls apart because the broker advisor involved can't figure it out, doesn't have options. And if there are options, they might not be the most elegant or user-friendly options. So Dave, in addition to being the CMO of Hint Connect, recently kind of restarted his own direct primary care practice and is working with employers. So Dave, can you tell us a little bit about your journey in working with employers and some of the challenges you faced with trying to pair your DPC offering with the employer's larger benefit offering?
Yeah. Before the Affordable Care Act, the pairing with catastrophic plans worked, with a self-funded plan worked, with health sharing was those were successful pairings. The challenge, once the Affordable Care Act came in 2014, many employers had certain requirements, and so they could not pair a catastrophic plan with the DPC. And so a lot of small employers that were in fully funded plans, they did not necessarily want to add DPC because it was too expensive and it was redundant. They already had a primary care offering, and then to add direct primary care benefit just added to the plan. And it was really confusing because it was two different things. There was a plan. There was a plan design with primary care, with specialty or hospital care, and then to add this direct primary care, how did the two integrate? It was difficult. And so sometimes people would say, well, am I supposed to go to my doctor that's part of the hospital network, or am I supposed to go to direct primary care? Am I supposed to go to both? Or it was just confusing. And so I think it'll be very helpful having an integrated plan. I've been waiting for something like this for 12 years. I've been looking forward to having a health plan where we are seen as part of the network, not as this tack on. And the other thing is as direct primary care docs, we left fee for service for a reason. We got tired of meaningful use with MIPS, with having to check a bunch of boxes. And I'm looking forward to partnering with a plan where we are understood for what we offer, and that the plan is built and wrapped around that.
Dave, has it been difficult for you to learn about the health plan and benefit space so that you can have informed conversations with employers that you're trying to sell to?
Yeah, when I first left fee for service, I didn't know the difference between the different types of plans. I didn't know that the employers that were self-funded were actually taking all the risk, that they paid the claims. And so I'd write for an MRI and say, hey, don't worry about it. Insurance will cover it, not knowing that the employer actually is going to pay that bill. Once I learned that large employers that are self-funded actually pay all those bills, and that if I'm trying to help the employer save money, then I started realizing, like, oh my goodness, we need to partner with the employers. We need to partner with other organizations to try to bend the cost curve in order to be able to reduce the costs for both the patients and the employer. that was an eye opener for me. Go ahead.
I was just going to say, I think it can be a really confusing landscape because there's a dynamic where once you learn everything changes. I think, we didn't hear the word level funded, our whole lives. And then all of a sudden last year it was on everyone's lips. So things change really, really quickly. I'd like to kind of take that segue and let Mike introduce his kind of what he's doing with XL Health Plans, because it's a really big change. It's a really big a really differentiated product, and we're excited to learn more about it.
Awesome. Well, thanks, Beth and Dave. Yeah, pleasure to be here today. And it's I've had kind of an interesting journey to work on and be a part of founding XL Health Plans. I actually am a former Division I college football coach at Colorado State, Colorado School of Mines in Colorado, if everybody's familiar with that, and went from there to working primary care. As people are probably aware, college football coaching is a pretty volatile industry. So a lot of hours, a lot of job changes. But in between coaching jobs, I wound up working for my mom at the office that she worked in South Denver. She's a primary care provider of 35 years. So that was my foray into healthcare, was through the lens of working in a primary care office itself. So I started in a primary care office because they needed someone to help at the front desk, do billing. So I did both of those two things and wound up doing just about every job in the office, referral management. I would work as an MA occasionally when some of them didn't show up to work. They're, "Oh, Mike, you're going to MA today." Even did things like run payroll and buy med malpractice for the docs. So I had to kind of figure out everything and all the ins and outs of a primary care office, getting prior auths done on the Medicare Advantage plans, and all of these things had a large impact on what I do now, because I was able to see the healthcare system from the inside of the primary care provider's office. And what really inspired me to get into healthcare and to do something about it was because I did the billing, people figured out that I could help them with EOBs, which is, everybody knows EOBs might as well be in a foreign language for most people who are working in the healthcare system. Like, I think to most consumers, it's like, these look like Chinese characters. I don't know what this is. This is some non-Roman language. So was helping a member with his EOB and realized that this member had a pacemaker put in for $600,000. And that was because of a medical error. So the pacemaker started falling off. They had to go back in and reattach said pacemaker. And then, the paid claim, not billed, but paid, was nearly $600,000. And I mean, that is someone's health insurance plan, writing a check to said hospital system for $600,000. That's exactly right. Obviously, the member only sort of cares, because really the reason he's having me audit his EOBs is because he knows his out-of-pocket maximum is $5,000. So when have I paid my $5,000, and when do I not care anymore? And that's honestly, with the third-party payment mechanism of health insurance, how most employees behave. And as Dave kind of alluded to, even the provider's like, well, it's covered by insurance. But the interesting thing is for in a lot of states, and even for any employer who's north of 50 lives, it doesn't matter if you're self-insured or not. Your premium is based on the historical history of your claims. So just like your auto insurance policy or any of you all's corporate general liability, workers' comp, or medical malpractice policies, those premiums are built around the risk there. And so if groups have lots of high claims, then the risk is going to go up, and the cost is obviously going to go up. So what led me into the healthcare space, for health insurance brokering space, I will say, from working at my mom's primary care office, is I kicked the tires on working for a hospital system and a couple of the insurance carriers, who certainly made it clear that the runway from the financial side of working for them to really understand how the money is changing hands in healthcare was going to be an exceedingly slow one. think 10 years plus. And I wasn't particularly interested in hanging around that long to figure those out. So I went to consider working at a couple benefits consulting houses to do some analytics work. Many of the consultants have large analytics divisions. And so
Can I just interrupt you first
yeah.
and can you just give like a quick primer about how do benefits consultants, like what do they do? How do they work?
Yeah, that's a great
What's their
question.
job?
So
So what are you going in to do there?
100%. So that's a great question. And many of the large firms you may have heard of, Willis Towers Watson or Aon or Marsh McLellan are probably the biggest publicly traded firms. And what they are is they're really insurance brokers first, health insurance brokers second. So, Aon is an extremely old British company that, has been around for hundreds of years, that sold insurance on all sorts of different types of products, farms and shipping and that type of thing. So most companies, probably most of you all as providers, buy your insurance from somebody. You probably have an insurance broker who comes in and sells you your medical malpractice policy or your general liability policy and a cyber liability policy and that type of thing. So most companies also buy their benefits from the same type of person, but in general, it's not the same person. Occasionally they may buy it from a payroll company, but typically there is a benefits consultant as well who will only sell health insurance. And what that turns into is they're typically selling a product from one of the four big benefits consultant companies. I mean, Blue Cross isn't one company. It's actually 37 now since Louisiana just got bought by Anthem. But yeah, the big four insurance companies, which we standardly, if I accidentally say the BUCAs, that's Blues, United, Cigna, and Aetna. And I'm kind of lumping all four of them together. So typically those benefits brokers, insurance brokers are selling, a company. It could be any of you all. Many of you may have an insurance broker, one of those four companies in the product. And then they have, like David mentioned earlier, a plethora of offerings where they can self-insure plans for larger employers, or they're selling fully insured products for smaller employers and everything in between.
And Mike, how do brokers typically get paid? Are they paid by employers, like a flat fee? Are they paid by the insurance companies to sell their product? What are their incentives for recommending a product to an employer?
Yeah, so typically they're paid commission, and the CAA does now require that brokers disclose their commission. There's some grayness to the rules, have not all been crafted from the feds in terms of what exactly does that mean. But yes, benefits consultants typically pay commission. Occasionally, for maybe some of the larger groups, they'll charge a consulting fee. But unfortunately for the employers, there is a lot of ways for them to create revenue streams for themselves. And to be frank, they're very creative at utilizing all those potential revenue streams. Unfortunately, at the expense of the employers primarily. Healthcare costs and the total cost of healthcare was not even $1 trillion back in 2000, and is now it's over $4 trillion now. So quadrupling in the course of only 20 plus years. And the more alarming part of that is its percentage of GDP will have doubled over those 20 years. So 20 years ago, healthcare only cost us 11% of GDP. Now it's going to be more than double that. Mm-hmm. So just in terms of, the U.S. economically, there's not really a net gain economically for spending more money on healthcare. It's just eating up dollars that could be used for other purposes in the economy. And to be frank, puts us as America at a disadvantage to the rest of the world, since they spend much less proportionally on healthcare than we do.
Yeah. Okay. Thank you for taking us to set the stage on kind of the, what's happening in terms of increased cost and what brokers do. I'll let you get back to kind of your story about how you created Excel. We appreciate that like level setting.
Oh, no, that's very important. And obviously for context of the story, if you don't know what a benefits consultant is completely, it would be confusing. No question about it. So I became a benefits consultant back in 2014. I actually had sold some individual products in 13, but really became a commercial benefits consultant in the back end of 2014. Worked for a firm that, in Northern Colorado out of their Denver office, and mostly started selling in Colorado. Cigna is the biggest market player. So wrote a lot of business with Cigna, and really learned about self-funding health plans, or just really the ability to be creative, because with that $600,000 pacemaker, my goal was to do something to help move the needle on healthcare inflation and this problem that faces our country. So what working with so in addition to those four large claims payers, you can work with an independent company called a third party administrator, and they will do the same thing. Well, they'll provide claims administration and customer service support, just like the four carriers will. And they're much more flexible, and they'll allow you to build a health plan kind of however you like. So I worked with one of those for the first time, and all we did was, there was a company that had a really high healthcare increase, about 80%, a little over 100 people on the plan. So they were looking at an increase of, six or $700,000 on what they were spending every calendar year. They had a lot of dependents on the plan, and they were worried about being able to afford paying for that. So all we did was carved out their pharmacy benefit manager. So typically the drugs run through a company called the pharmacy benefit manager, who sets the pricing and fee schedules both with the manufacturers and the pharmacies themselves. The three largest ones in the US are CVS Caremark, who owns Aetna, Express Scripts, who is owned by Cigna, and then OptumRx, which is a United Healthcare subsidiary. So between those three entities, they control roughly 90% of the market share of that space at this point. So they are the big three players. But if you work with an independent pharmacy benefit manager, which is not affiliated with those three, you are able to get kind of creative like we were. And we work with ones that pass through and don't keep any of the rebates. They pass all of the rebates back to the clients, so the client can reap the gains. But we also are able to procure the drugs using manufacturers assistance programs, where you're getting the drugs for no cost to the plan from the, like, say you're on a Humira is extremely expensive, pushing $100,000 a year. Well, you can either get Humira for free from the manufacturer's assistance, where if a person makes below about 400% of the federal poverty line, they can get that drug for free. And then, or we can import that drug from Canadian pharmacies via mail order, and the drug will cost, $15,000 a year instead of 80. So we were able to pass all of those savings back to the employer and cut their costs by over $500,000 just by switching out that. And the company was still using Cigna's network after that. So it feels just like a regular plan. You can walk into your provider, you're using the same network that Cigna built, but we have this solution on the back end for the drugs. So after that, I thought, hey, this is really important. I'm going to go do this for more of my clients, only to find out I wasn't going to be allowed to do that at my firm, because moving the two Cigna groups that I wanted to move would have conflicted with our bonus program. So we make a very large, very lucrative override bonus from the carriers. And that's where a lot of these problems occur, is that there's huge conflict of interest around benefits brokers making big bonus programs. And literally, I was not allowed by my firm to go put this solution in force on two of our clients, because it would have cost our firm too much money in terms of the reduction in the value of the bonus, which requires persistency. That's the biggest thing, that the carriers must retain all of the brokers have to keep all that business with said carrier.
So you wanted to do the right thing for your employer, but you couldn't. So fast forward us a little bit to kind of where you are now with Excel Health Plans, because I want to make sure we have time to get in
Absolutely.
to kind of what, like, the difference between your experience with the traditional brokerage and what the experience with Excel Health Plans is like now.
Absolutely. So, so what we moved to was a different model when I started my own firm, and we moved to what we do now, which is kind of a proactive PPO in about 2018. And the reason for that PPO, like the PPO provides some different benefits. It's actually modeled kind of after a Medicare Advantage plan. So like I said, working at my mom's office, we learned a lot about how members are engaged and steered and redirected using prior authorizations, that type of thing. So there's a couple programs so the primary benefit of Excel Health Plans is guiding employees to zero cost care that's high quality in what we call our disappearing deductible program. Do you want, David, why don't I share my screen to click present right here?
Well, and one thing, we've been talking about this, we're talking about lots of different things like surgeries, for specialty care, hospital care, for medications. It's able to steer to places of value in order for patients to get decreased costs that they don't have to pay the deductible or the coinsurance.
Dave,
Yep.
what has your experience been when you have employees who have just a kind of a standard network from one of the big insurers?
So most of the time, if they've got a high deductible healthcare plan, they have to pay 100% until their deductible's met. And then there's usually a combination of an 80-20 co-insurance. They have to pay 20% until the out-of-pocket max is met. And then the insurance will pay for everything. I'm not very familiar with the disappearing deductible. So this is really exciting to me that we can have places of value that are high quality locations, particularly ambulatory surgical centers to get surgeries, where they're a fraction of the cost. That a lot of patients have no idea that that's the case, that they're better care, lower cost, and we're helping to steer them. And with Excel Health Plans, they're incentivized and giving the nudge to be able to incentivize and steer patients to those places.
Yeah, I think that I love this because, there's so many people who have insurance, but truly they're underinsured. When you're talking about spending 4, 5, 6, if you're a family, $13,000 a year in consumer-driven health plans, because with the theory that it's your money, so you're going to spend it, right? But people don't have $13,000 a year to spend on their basic healthcare needs, and everything is so expensive now that even getting a test, an MRI or an ultrasound, can be more than people have to spend for healthcare for the year. So those become really difficult conversations clinically. Mike, why don't you go ahead and show kind of a little bit more deep dive into the disappearing deductible program of Excel Health Plans?
Yeah, we'll do. So I will show you just a few things. This is some pretty interesting things to kind of give everyone the overview of how the disappearing deductible lowers healthcare costs. So this is just a real quick example. I just picked a market, Miami, Florida, where we're looking at what the billed charges are for a specific procedure. So and the disappearing deductible has a dual focus. We like to say it aligns the incentives for the member between both quality and price, because we do audit the providers using a company called Perception Health on their quality metrics, and then also on price. So with price, you can see there's a huge variation. This is a total joint replacement in
So
Miami.
I'm not seeing am I supposed to be seeing
Yeah,
you guys see it?
Oh, there you go.
There we go. Yep.
Got it.
Okay,
It's small. Is there any way to blow it up?
I don't know. Maybe I can zoom in.
I think this is probably the best we can do here. So
Okay.
No, that doesn't seem to be helping.
you can just describe it if people.
Okay, so anyway, what I'm going to show you here is, let me see if I can cut this down. Maybe I'll go for Miami itself. There we go. So now you can see it a little better. So let's just go to Miami because I don't know where South Miami is. Miami. Go to these 7 providers. All right, here we go. So here's North Shore Medical Center in Miami and Kendall Regional Medical Center. They bill $154,000 and $143,000 for a hip replacement. So what that means is they're probably going to bill about that much. The discount's probably going to be about 50%. These charges, this is a database that pulls information directly from the hospitals as to what they bill the PPO networks. Roughly going to be about a 50% discount off of these bills in suburban areas. So probably say 70,000 plus the device, plus the surgeon, plus the anesthesiologist. So you're probably looking at most of these locations at anywhere between, here maybe 50, and at these other locations probably $80,000 or $90,000 for a total joint replacement. So that's kind of a baseline for you all, is how expensive these procedures are inpatient in a hospital. And this is a very standard procedure that happens all the time. Can you guys see my screen now?
Yes.
Okay, cool. So this is another surgical hospital using the platform we use called Coral, actually also built by a doctor. Dr. Keith Smith at the Surgery Center of Oklahoma was the first person to pioneer publishing all of his prices online back in 2000.
Your screen hasn't changed for me. It's still showing the Miami. There you go.
There we go.
That's great.
Is it switch now?
Yeah, looks good.
All right. I guess there's a lag on this thing. So, all right. I just wanted to make sure. So this is, so here you can see that at the Hospital for Specialty Surgery here, just north of Miami, we're able to get a total knee or a total hip for $20,000 and $23,000, and that is all in. Capitated price, provider gets paid in 5 business days or less. And so because Dr. Smith did that, he worked with another gentleman to build this Google Maps overlay platform, and you can purchase bundled surgeries or imaging on this platform, pay the provider very quickly, and there's no patient recovery. So they're able to post kind of the lowest baseline price up front, and we're able to bring some consumerism into healthcare.
And so this to me is, there's a lot of parallels here between direct primary care and direct care in the rest of the system. So, if in the partnership where we have patients who may have a direct primary care practice through HitConnect, would the DPC have access to this platform to see where they could refer?
Yeah, typically we can help pull a list of these. It's usually easier. We prefer that, we'll use our care navigation team to do this for you, but you can be made aware that, this specialty hospital surgery center is the one you want to, and then we'll make you aware of the locations where, like, the biggest thing is imaging. That's what you're going to get the highest volume of. And I can show you real quick, just like the spread on imaging. So like my business partner, Dylan, he's a 2-time stage 4 melanoma survivor, talking to providers. And he had a CPT scan that he needs to get every year. And the last time he had it done, when he was working for his former employer on a United Healthcare plan, they wouldn't let him do the full PET CT with the dye because it was too expensive. But they approved him to do a regular CPT scan, full body, and it costs $11,000.
Every year he needs that.
Yeah, and he needs that every year. But if you look here at, this is just MRIs, as all these guys have published. Somebody else will have. So if you look at like CPT scans here on our website, all right, here we go. If I can find one. Saw one on there. Ultrasounds. Usually CPT scans are going to run, I don't know, somewhere. Yeah, so here we go. CT scans starting at $300, full body CPT. Yeah, they're going to be, less than $500, as you can see from here. For
are patients on their own to figure this out, or
no, absolutely. all of this stuff is done by a care navigation team. So that way the patient, like all they do is call a 1-800 number and then we take care of everything. And if we're working with DPCs, what we actually want is for you all to hand them off to our care navigation team, usually a warm transfer live while someone at your office is doing it. And then we'll set them up on exactly where we want them to go for whatever care you've decided they need. And that way the member's going exactly where we want them to go. And I think the biggest thing to touch on, Dave, is how that creates ROI back for the DPC plan, because you touched on at the beginning how difficult it is to sell direct primary care to employers when you're just seen as an additional expense to that BUCA carrier plan.
Yeah.
Mike, I have a couple questions for you. One is an audience question. Does Coral have data across the United States?
They do. They basically have data in every single, every single metro area in the country. And then there's actually imaging, even in most rural areas. Obviously, kind of similar to the demographics across the U.S. It's a little more sparse as you get further west. But yeah, even in a lot of small towns across the U.S., they'll have an outpatient imaging center where we can send people to. But, no different than a lot of things. If you get into small towns in a rural area that maybe only has a Walmart, the surgery center is probably an hour and a half drive away. But the plan does reimburse for any travel expenses for any members being required to drive. And really, if you look at any of the urban areas, we're going to have multiple options for orthopedic and general surgery in any of those markets.
All right. I have another question for you, Mike. If the great thing about DPCs is a lot of times they've already developed relationships with cash pay or direct pay providers that they trust in their communities. If they don't see those providers on Coral, would they be able to refer them in?
Yes, they would, but we want that referral process to go through our care navigation team.
Mm-hmm.
Just because, as you might imagine, most of these imaging centers and these surgery centers still do most of their business through the traditional insurance plan and bill it. And it's actually totally critical that we work through our care nav team because, like this surgery center in Miami that I just showed you, I'm sure that they accept the network that we typically use in Miami. So if you referred the member there without going through the process, then they're going to pay our network rate. And that surgery center probably bills more than twice as much on their PPO network than they do as part of the bundles because of how long it takes the provider to get paid, because of the hassle of dealing with insurance, and because, to be frank, as you guys all know as providers, how much the provider is losing to collections and what they're not collecting back from the members. Yeah. So because the provider doesn't have to deal with any of those things, they're giving us what's effectively the lowest price up front. So, but it is critical that we go through that process. So we utilize that direct payment mechanism through Coral rather than the network. Because if the member just shows up to said facility and says, I need my bundled surgery, honestly, the person at the front desk is probably not going to know what they're talking about.
Got it. So we would need to get them contracted through Coral, get those favorable rates first. But there is the opportunity for DPCs to continue to work with community providers that they already know.
Yeah, 100%. And sometimes it doesn't take a full integration with Coral for us to get that done. Like if you have a relationship with said provider, it's really as simple as ask them what are their cash pay rates. Just know that we're going to compare them up against Coral because the plan benchmarks, roughly what's under 150% of Medicare's reimbursement on an out of network basis. And the plan is willing to cut deals on a one-off basis, what we call single case agreements, to send someone to said provider. But just know that the pricing of the bundle needs to be in that ballpark from a price range in order for the member to get that care for free.
Got it.
And I had dinner with Doug Geinzer just a couple weeks ago, and he said if there's any provider, location, vendor that is a low-cost vendor, just reach out to him, and he can add it within just a few days. He said, so they're very responsive. Hey, I want to talk to you, Mike. Just want to know Well, and before you answer this, I was going to give a definition of direct primary care, but how does direct primary care fit into the plan? How are DPCs, how are patients incentivized to use the DPC? Most of the audience are DPC practices, but for those that aren't, the minimum definition for DPC that we're using is unlimited visits for primary care, preventive care, acute care, chronic disease management, specialty coordination, having after hours access by phone 24/7, having some type of messaging system electronically, minimal wait times, and having same day, next day access for urgent issues. That's the minimum criteria for DPC that we're using in our national network. But Mike, how does Excel Health Plans incentivize patients to utilize the DPC, and how does it wrap around the DPC?
Yeah, and I think that's a critical question, Dave, because that's a lot of why, and it's been difficult for DPC to scale, is because there's no, while DPC can affect employers' ability for cost, it doesn't necessarily do it when it's sitting alongside the wrong type of benefits plan. And what I mean by wrong is that, a traditional, one of the big four carriers plan doesn't provide any incentives for the behavior we just talked about. So like my dad got his hip replaced a couple years ago, back in 2019 in South Denver, and he went to Littleton Hospital and it was $130,000 total paid for his hip replacement. But my dad worked for Lockheed Martin. Lockheed Martin uses Cigna as the administrator. So the truth of the matter is that if my dad went to use that Coral bundle for the $20,000 hip replacement, which is available in South Denver, it actually would have cost him more money than the $130,000 hip replacement because of the way the plan is built. So because of the way the plan is built, if he wanted to pay that, it would have been an out-of-network benefit, where my dad has triple the out-of-network out-of-pocket maximum and half the co-insurance. So it would have cost him $10,000 to do that. Now, and then here's the other problem. It costs him, even if he would have used the network and gone to the same outpatient surgery center, which is 4 miles away from the hospital he got it at. And by the way, the same surgeon can operate in both locations, which is frequently the case. He could have gotten that hip replacement done for $130,000 at Littleton Hospital and probably about $45,000 at Dry Creek Surgery Center. But the thing is that my dad will owe the same $6,000 on his Cigna health plan either way. So thus he doesn't even care. And that's really how the health plans are built. There's no incentive to control healthcare costs for the carriers. So to be frank, they don't control healthcare costs.
So the incentives between what the providers get paid, between what the employees see as their cost and what the employers feel as their costs, are totally misaligned. And
Exactly.
in Excel, you're working to align those. And DPC, I think DPC can fit in because it's such a strong patient benefit. It's felt so quickly and positively by patients, but also there's that alignment between creating, a network that works with DPC, a clear referral pattern with DPCs, and then kind of the that member experience of kind of no out of pocket for DPC, no out of pocket for the rest of their care, and employers see lower costs overall.
Exactly. Yeah. And a typical health plan, you're seeing, only a couple % of the healthcare spend being utilized on primary care, which is actually too low, and I'm sure, Dave, this. If you look at most of the other Western European countries, they spend double or triple the amount that we do on primary care because the average person visits the doctor much more frequently than they do in America. But all these countries, as we just went over, also spend half of what we do on healthcare costs. So there is a correlation with spending more money on primary care and lowering of healthcare costs. But what we can do with the benefit is make that correlation much more direct. So we get discounts on direct primary care, depending on our underwriters. They range between 6 and 10% off of the total price of the plan for utilizing DPC. And the reason for that is our ability to get the members to take those incentives that I just showed you. Get the member in South Florida to go to that outpatient surgery center for the hip replacement instead of go inpatient for the hospital. The rate at which the members will accept redirection is massively higher when a direct primary care is involved, probably close to double. I mean, our redirection batting average is about 50% right now. And what we've seen when we're working with direct primary care is that it's above 90%.
So redirection means that for downstream care, for specialty care, employees are going to the place where you have the good deals, where you want them to go. And it's because they listen to their direct primary care practices. They trust them. So they trust the recommendation.
Exactly. And
And
Excel Health.
And this is where we get the cost savings for employers and for the plan. And so we can actually get a lower cost for our employers when they get their renewals. How does this compare against a BUCA plan, Mike?
Yeah. So typically, we're working mostly with PPOs. So really at Excel, we work almost exclusively with PPOs. And so we're typically using in Oklahoma and Texas, we can utilize the UHC network. We have a little less flexibility when we're there, but around the rest of the country, we're using primarily networks called PHCS Multiplan and First Health, and it does totally depend on which market you're in. PHCS tends to be better in the Northeast by a lot, and then First Health tends to be better around the rest of the country. But the reason is that most of the other carrier networks have rules against tiering and steering, like we're talking about here, where they're going to say, hey, you can't incentivize the member to go to the outpatient surgery center over the hospital as part of the rules that Cigna or UHC or Blue Cross create, versus those other networks that we work with have no rules against that practice, which is why we use them. So we're typically using, like, First Health is actually owned and negotiated with Aetna. It just has a little bit worse network discounts. So, but we're still getting lower pricing up front than the BUCA carriers are by about 20%, because we're able to successfully redirect a bunch of these claims. And to be frank, for all of you all, that's the biggest thing to employers, is they're looking for a lower net cost and better value up front. It's hard to pitch an employer on, hey, buy a self-funded plan that's going to be the same price or more expensive, and hopefully you'll save money. If you can come in and say, hey, you're going to save 20% up front, sometimes that difference is going to be the difference to pay for direct primary care right there in the savings.
Yeah. So I think, Mike, we have a lot of questions coming in. I think you just answered one question. Alan Pershing asked, am I understanding this correctly? Our best bet is to fit DPC into employer's existing health plan is to offer a completely different health plan through Excel. And so the answer there is yes, because of the reasons that you just described. I want to backtrack a little bit to when we were looking at Coral and the downstream costs. We got a question in from Brian that said, are these fees negotiated with Excel, or are these fees available to anyone in Coral?
I mean, like, you guys could sign up for Coral, but the problem is the health plan needs to be set up to receive and pay Coral in order for it to work. So it's a pretty intricate process. You definitely need a benefits consultant with a lot of experience who knows how to set that up. So yeah, I mean, you can go, like, for instance, if some of the providers on the call, there is like physical therapy sometimes on Coral and dermatology. So there is actually some specialists who upload their fee schedules and those dots inside of Coral, but Coral actually negotiates all those fees, and we just access their database.
Yeah. And so that kind of speaks to the work that you've done with a TPA at Excel Health Plans to fit all the pieces together that you feel like are the right pieces. So, we're talking about, like, working with Coral, the PHCS and other networks that you've done, the direct PBMs, the international PBMs that give employers the lowest prices, and DPC and other primary care options in addition to that. And so that's what Excel Health Plans is. It's rebundling the right pieces for employers.
Exactly. And that's exactly as we describe it, is it's a repackaged solution that drives those incentives to the high quality, low cost locations, and both parties win. The employer wins, the member wins, and then obviously DPC can be a part of that win because you're now showing your ROI back to all of the groups.
Yeah, awesome. Dave, will you tell us a little bit about kind of why we're talking about this with why Hint Connect and Excel is a good fit, and then how direct primary care practices, if they're working with employers who aren't familiar with Excel or kind of can't figure out how to fit direct primary care into their offering, can work with Excel. That might be a question for both of you.
Well, the first thing is, I must say, I left fee for service 12 years ago, and I feel like I had no autonomy, no authority. I was told how to practice, and I escaped it because I felt like it was a very unhealthy relationship. and I've been doing this for 12 years. And first off, I want direct primary care to take over, and I think this is the way that primary care should be delivered in the United States. And I've got lots of colleagues that are still in fee for service that hate their jobs, and I really would like to have them join us in this direct primary care movement. And I'm excited that as we are looking at new avenues in ways to unlock and make it easier for employers to tap into direct primary care, so we get better care for the patients, it's cost savings and better quality of care for the employees and the cost saving for the employers. But also, I'm really looking forward to having more of our colleagues join us in this movement. And I think that this is very exciting because it is a new way. We've got, and Mike was telling me that the employers, the size of the employers, this goes down to employers as few as 5 employees. So it can be very small employers, but it can be large employers too. This is not just I remember we mentioned the 50 employer mark because of the Affordable Care Act. So I think this is unlocking a market and helping both the DPC movement, direct primary care patients, and the employers. So that really excites me and motivates me.
So what does the conversation look like if a DPC is working with an employer? They say they have, this is a frequent scenario. One of the leaders in the company is a patient of the DPC, and they say, how do I offer this to my the rest of my employees? I love this, but my broker has never heard of it. They don't know you. Like, what's the first step that the DPC can take or help the employer take to learn more about Excel health plans, Mike?
I would say the first thing to say is to send it through, by our channel means to us. The broker relationships, Dave, I'm sure you can speak to this, can be very unique with employers. It just totally depends on 2 things: how close that employer is with their benefits consultant. Some employers absolutely love their benefits consultants and will never part with them under any circumstances. And some employers don't care at all, and everything in between. If I would say that's a situation that you need to navigate a little bit, ask the employer. Sometimes the CEO honestly doesn't know. So you may be treating the CEO of the company, and most times the CEO is actually handing that decision off completely to the HR director. So that's typically how it goes, but you do want, the whole C-suite involved. And I would say if you're not comfortable having that conversation with the benefits consultant, bring us in at Excel, and we can kind of go behind the scenes, and we'll let you know whether or not we think this benefits consultant is at all open to sell Excel. Because, most benefit consultants are probably, more agnostic than anything else. And if their employer says, hey, I really want to do this, they'll check it out and they'll probably do it because they don't care and they don't want to lose the business. But some of them are, enticed by those bonus programs, and they won't work with you no matter what. So if you're not comfortable having that conversation, we're happy to. And then obviously the understanding from our side will be that, we're going to help them install your direct primary care sitting next to an Excel health plan. So the incentives are aligned. And then beyond that, if you already have the entire company as a client, then just work with whoever your contact is, and we can come in and work with a broker. And if you ever find a group that says, hey, we're sick of our broker, just come to us direct and give us some information on, what that setup is. If you have any information, and we're happy to find you. We have active business with over 80 benefits consultants nationally in most markets. And then we quote business with over 250 of them. And we know the best, the best ones for you all to work with. So if you call and say, hey, we have a group, they're ready to move, we need Excel in there, we'll put you in touch and help walk you through the process with a benefits consultant who will close the deal for you.
And Beth, my experience with employers, when I ask them how do they like their healthcare plan, most are like, most feel like it's a necessary evil. And what they hear from their broker time to time frequently is that, okay, there's going to be double-digit increases and there's nothing we can do about it. That's just the way it is. That's the way the health system is set up, and healthcare is expensive.
Yeah.
And my response to them is no, there are creative ways to do things differently. Just because you've done things through a specific plan in the past does not mean that that's the way you have to do them in the future. And this is why I'm really excited. I think this is just a novel way of approaching a healthcare plan. I know we're kind of running low on time. One thing I did want to go back to is the direct primary care nudging. Excel Healthcare Plan does have a way to, because patients can still go to a fee-for-service primary care. They can also go to direct primary care. How are patients steered towards direct primary care with Excel Health Plans?
Yeah, so the biggest thing there is, once again, a plan design incentives. So the plans are set up where the member has a copay. So, if they want to go see a primary care, they have a copay and they use the network. The biggest advantage of direct primary care is obviously they have no copay. And then we can work with you all. Like if you have your own in-house, David was talking about us, lab deal, we can pay those claims for lab work directly. We do have a contract directly with Quest. So if you all send labs to Quest or you can simply send those labs directly to Quest. And you can charge us a draw fee if that's not part of your DPC fee. But if it is, you don't even have to do anything. You can just submit send the stuff straight to Quest, and we have a direct contract, so it'll be free to the member. Or like David said, he has a LabCorp contract, so you can just pass that fee back to us. At your contracted rates are going to be low enough that we'll classify those labs as a disappearing deductible. So all of those benefits from DPC are going to be available to the member. And that's the biggest thing, is it's free. And we're going to help you work with the benefits consultant to make sure you can market that back to the client, is that they don't have to go in. And it aligns with Excel very well because the DPC is another thing that's part of the disappearing deductible.
Yeah. So I want to, that leads us into a couple of recent questions that we got, which are, how, as a DPC practice, how do you collaborate with Excel, or how does this work in practice if you're a Hint Connect provider? So Excel Health Plans and Hint Connect are partnering. So if you're part of Hint Connect, and Excel Health Plans is offering a plan with direct primary care embedded, as a Hint Connect provider, you would be offered alongside that. There's not much more you would have to do. If you are, as Mike said, you have those charges, we can help aggregate those, help submit those. If you need more information about Hint Connect, you can reach out to us. And then as part of, like Mike alluded to before, once these employers are implemented, if you're part of Hint Connect, a DPC, and you're working with Excel Health Plans, we'll give you information about how to access the care navigation team with Coral, how to process extra fees, kind of what the whole member's benefits are, so that it's really easy and push button. And there's nothing else that you have to do in order to be tagged to the deals going through Excel Health Plans.
And Dr. Miller, so this is all built in already with Hint Connect. So if there are patients that are within your catchment area, you're going to be highlighted. If you're the referring doctor to Excel Health Plans, you will be highlighted as the primary driver. But if there's patients that are outside of your catchment area that need to go into other locations, those patients will be available to sign up with any of the DPCs within the Hint Connect network.
Awesome. So going back through some of our questions here, I just want to make sure that some of these questions were answered in the chat, and I don't think everyone on every platform can see the chat. So there was a question about what states is Excel in. Excel is in all 50 states. In some cases, there are minimum size restrictions, but in 47 states, it's just 5 members and up. Excel can sell. Hint Connect is in 35 states right now. There was a question, let's see, what percentage of healthcare costs are administrative? And Mike answered about 20%. So that's a significant amount of costs that are not going toward direct care provision and the clinicians who are delivering that. How do you know clinicians that are offered through kind of the Coral referral system are high quality? Mike shared that used Perception Health. Do you want to talk a little bit more about the data Perception Health uses, or anything else to know about Perception Health and how it can report on quality for downstream clinicians, Mike?
Yeah, I don't know if anybody here is familiar with like Quantros that pulls and aggregates CMS data. So it works pretty similar to Quantros, but the reason we don't use Quantros is because Quantros does only inpatient scoring. So it's not effective for, obviously we're referring everyone to outpatient. So if we got scoring only for inpatient, that's not super useful. So what Perception does is they pull data from CMS as well as the claims clearinghouses, and they use that to build some algorithms and create some quality scoring metrics. And we're typically, honestly, interestingly enough, most of the bundle providers are pretty high quality. They kind of have to be, we found, almost by nature, because all these ones are warranted. So, if they screw up, they have to make it right as part of that bundle rate. So it does put a lot of pressure on the surgeon that, you can't afford to have a surgeon who could screw that surgery up, because you're going to eat it instead of the plan, which we like. But they measure all the quality metrics on outcomes and quality. And we're typically only referring to the best 2 providers on that scoring side.
Yeah.
Hey, Mike, there's a question about diabetes and insulin. You want to talk about DiaThrive?
We work with a company called DiaThrive, and they do a great job of diabetes and insulin, and they can actually do coaching. And we'd actually really recommend that if you have, especially any diabetics who are not managing their conditions well, we actually want you to help us get them signed up on DiaThrive. They'll have a personal health coach, and they get all of their testing supplies, strips, and then as well as insulin at we get it at a very low cost through them, and it's also free to the member.
That's awesome. So we have 3 minutes left. I want to get to Aaron's question, because I think that it's a good one. We can, to segue into that, we'll share information about Excel Health Plans with the attendees of this webinar after the webinar, as well as probably do some summary of the Q&A, given we've got so many and such good questions. But Aaron asked, how do I get a list of benefits brokers that are working with Excel in Utah?
I share my contact info. Send us an email, and we'll make an intro to some benefits consultants in your area.
Dave, Mike, any parting words? Anything that we haven't mentioned about the partnership or Excel Health Plans that you think the attendees of the webinar should know?
Well, I'm going to say that the direct primary care movement is gaining steam with the employer space. Initially started more with retail, and as time goes on, we're moving into more employers. About half of the country gets their healthcare through their employer, and we really need to move into this area in order to be able to transform how healthcare is delivered in the United States. I'm excited about this product. I think this is a step in the right direction. I'm excited that we can be able to unlock some more volume for DPCs to fill up practices and to entice more of our colleagues to come and join us. And I'm excited to partner with Mike and his team.
Awesome. Mike, anything else you want to add before we go?
I would say that just reach out. I shared my contact information, and we're happy to work with y'all and help connect you with our benefits consultants and go from there.
Awesome. Well, thanks everyone for joining. Mike, Dave, thank you so much for your time. I know your time is precious. So we'll send contact information, follow-up questions, FAQ after the webinar. And I hope everyone has a wonderful day.
Thanks.
Thanks, guys.